A surgical airway is needed when the upper airway is obstructed or an endotracheal tube cannot be placed through the vocal cords, for example due to edema of the glottis, laryngeal fracture, or severe oropharyngeal bleeding. Surgical cricothyroidotomy is faster and easier to perform, associated with less bleeding, and therefore preferred over tracheostomy for most patients who require an emergency surgical airway. Inspired air is best provided with a tight-fitting oxygen reservoir face mask, although others can improve inspired oxygen concentration. Changes in oxygenation occur rapidly and are impossible to detect clinically, so pulse oximetry must be used at all times. Be alert to changes in intrathoracic pressure, which can convert a simple pneumothorax to a tension pneumothorax or even create a pneumothorax secondary to barotrauma. Also, gastric distension can occur when ventilating the patient with a bag mask device, which can result in vomiting and aspirating. Before the patient arrives, the team leader often assigns an airway manager and identifies any consultants who may be required. If a definitive airway is likely required, consider preparing appropriate drugs for sedation and rapid sequence intubation before the patient arrives. Equipment for managing difficult airways should be readily available. Because patients are often moved, the team leader should identify who is responsible for managing a patient's airway and ventilation after intubation.